and is not necessarily what I view as probably the most important part of the project. There was an attempt, pretty successful one I should say, to focus on infants from diverse populations historically underrepresented in biomedical research. And then I think what was probably the most sort of innovative component of this is the third aim, which is to assess the ability of nursery staff who had received some training to return results of whole genome sequencing on the babies. And really the premise of this was that as genome sequencing becomes more and more widespread, that the trained genetics workforce is simply not scalable. There just aren't enough genetic counselors and medical geneticists, not now, likely not ever, to deal with the volume of genetic return of results that one could imagine if genome sequencing becomes as widespread as I think most of us would hope that it would be. And so the question was, could we train non-geneticists to return results in a way that was both responsible and accurate? Now, the inclusion criteria for babies to be offered sequencing are shown in green, and the bar was pretty low, probably lower in many cases than you might use in clinical evaluation, I would guess. So these were babies in the first year of life. Some of them wind up with very extended stays in the NICU, as I'm sure you know. And then they either needed to have congenital anomalies, not of a kind that are typically not associated with genetic changes. Things like gastroschisis, which are rarely due to a defined genetic cause, were not among those that were included, but other congenital anomalies, or what I describe here as an unexpected course, a child who was having seizures where there wasn't an established etiology for those, or just wasn't doing well by whatever measure, out of range of what you could expect for their degree of prematurity or whatever other medical problems they had. Now, excluded were babies where there was an obvious chromosome abnormality, a teratogenic exposure that could explain their phenotype, or a known or highly suspected congenital infection. And I should also emphasize that this was, for the most part, not rapid genome sequencing. There was a small piece of it where we tested that, but mostly, as you can see, day 70 and sometimes beyond that is how long it took to return results. And so in this instance, we did not view the genome sequencing as the primary approach to establishing a diagnosis. If the clinicians, and that could include genetics consultants, had a suspicion of a particular genetic problem that would be solved by a particular test, they would order that test and frequently make a diagnosis long before the genome sequencing came back. So we didn't view this as intended to be the primary diagnostic approach. That being said, as you'll see, there were many instances where diagnoses got made based on genome sequencing that were not on anybody's differential diagnosis at the time when they were seen. So the idea here was to enroll the baby and the parents. They would do genome sequencing, this was whole genome sequencing, only on the proband, and this was a cost-saving issue, so they would take DNA from both parents, if available, and use it for Sanger confirmation of a variant that might have been found in the infant, but the parents were not sequenced. And then they would do the sequencing, they would do a confirmatory Sanger test if they saw a pathogenic or likely pathogenic variant, and then there would be a return of results, and I'll go into a lot more detail about that in a few minutes. Well, as I said, one of the kind of mainstays of this was testing the ability of nursery staff who are not trained geneticists to return results in a responsible manner. And the Hudson Alpha Group put together a half-day training program that was mainly in person, although there was a remote option available. And the idea was that it included a little bit of didactic training and then some role-playing exercises, small group discussions, simulations, to try to get the nursery staff, and this was mostly physicians and nurse practitioners and people of that sort, get them to a point where they would feel comfortable returning results. And there were surveys done pre and post training, and so the results here on the left are confidence in reading and interpreting reports, and on the right, confidence in managing patient care based on whole genome sequencing results. And the light blue are the pre-training results, and the dark blue or black, whatever it is, are the post-training results. And so the level of confidence, self-reported confidence in reading and interpreting results was either not at all or a little or somewhat for the most part. And you can see it moved significantly to the right after training. And this is just individual reports of confidence. It's not testing them to actually determine their accuracy. It's simply their own self-assessment. And in terms of managing patient care, there were some that felt pretty comfortable even from the beginning. And again, self-reported confidence at least shifted to the right. Now, one of the things that was put together to support this was a format of reports. And actually, the report, which you probably can't read anyway, but on the right is a patient-facing report. But the physician-facing reports were also designed to be user-friendly, I guess you could say, to be free of jargon and to really make it clear what the most important issues were. This is, I guess in my mind at least, one of the things that I think contributes to errors, whether they're made by geneticists or non-geneticists in reading reports, which is that typically the reports that are issued from testing labs, I think, are technically accurate. I'm not quarreling with the accuracy of the information, but first of all, no two labs are alike in terms of where they put information. So you don't really have any kind of guide as to where to aim your eyeballs to actually see the most important information. You have to figure it out from the company that you're working with. And if you use the same one all the time, I guess you get used to it. But if not, and that's often true because insurance mandates testing be done in different contexts. So first of all, the report formats aren't the same. And secondly, they do tend to be pretty jargon heavy. And as a result, I think, invite anybody who's less than an absolute expert to misinterpret those reports. And so there was an effort made here to be clear, jargon-free, and as straightforward as possible in terms of the way the reports were worded. So if you just look at the numbers now in terms of diagnoses made, over the course of the study, 638 babies were enrolled, all of whom had their whole genome sequence completed. This included 62% that were trios. As I mentioned, the parents did not have sequencing done. They only had DNA saved for Sanger sequencing if needed. Slightly more than 50% were male. 49% were non-white, but 74% fit diversity definitions that were in use by the CSER consortium. And you can see race, ethnicity, geography, and income. So if you look at the genome analysis, as I said, all of them had completed their whole genome sequencing. There were 29% in whom a pathogenic or likely pathogenic variant was found that was believed to be a primary diagnosis. Parents could opt into secondary findings using the then in force ACMG list, and 1.8% had a secondary finding return. There were a subset of 15, as you can see, who had rapid, 6-day turnaround. May not be the most rapid that you can get these days, but rapid whole genome sequencing. And they had a 47% diagnostic rate, which I think reflects the fact that they were sort of hand-picked as instances of babies that had a high probability a priori of having a genetic cause for their condition. The 29% is, I think, concordant with what a lot of groups find. And remember, the bar was pretty low here, so we were not surprised that many of these did not have an underlying genetic diagnosis. Now, by now, all of the results have been returned. As you can see, 29% with in-person visits, 61% by phone, and then there were a handful, 10%, where a certified letter was sent, which usually means it was difficult to reach the parents. 62% of the babies had been discharged from the nursery by the time the results were ready to be disclosed. The average turnaround time altogether was 83 days, and there were a significant number of babies who were deceased by the time that return of results occurred. Here's some of the same information in a graphical form. So 29% got a definitive or likely diagnostic result, inconclusive or largely variants of unknown significance, and there were a lot that were not returned. Here are just a couple or handful of the most common diagnoses that got made, but there were a pretty large array of diagnoses outside of this. I should say, and I won't talk about this in any detail, there also was a kind of a branch of this looking at long-read sequencing on about, I think, a dozen or so, and there were some diagnoses made there that are not included in this list. Well, when it came to return of results, as I said, the way that was done was that the babies were randomized, and some were having their return of results done by a nursery staff person who had been specially trained, as I described a few minutes ago. All of the return of results discussions were audio taped and were audio recorded, and then Hudson Alpha genetic counselors would listen to these recordings and score them for the occurrence of errors. Now, there were 3 categories of errors that were identified. I'll read from right to left here. Minor errors were things that would not have a major impact on care, but were technically wrong. Give an example here where they say the gene is on chromosome 6, where it really was on chromosome 16. Something that should be corrected for the record, but doesn't really change the way the care is provided. Then there were major errors, things that would have a potential impact on patient care and clinical decision-making. For example, misquoting the recurrence risk, saying it's 25% instead of less than 1%. In instances like this, there was real-time feedback provided, and things were corrected over the course of hours to days to make sure that the correct information was imparted to the family. And then the third category were what are described as high-risk safety errors, where, for example, some invasive procedure was deemed to be indicated based on the result, or maybe an invasive procedure that otherwise would have been indicated is not done, or, for example, the wrong test result was reported back to the family. That would get immediate real-time feedback, as you might imagine, and there was a data safety monitoring board that would be notified. None of those actually occurred, as it turns out, but that was something that the counselors were scrutinizing for. So if you look at overall error rates, then on the left are shown the non-genetics providers, and on the right are return of results by genetic counselors. So there was obviously a significantly increased rate of errors by the non-genetics providers as compared to the genetic counselors, but neither group was perfect in terms of their return. As mentioned, those major safety errors did not occur in either group, but there was certainly an increased frequency of major or minor errors in the non-genetics providers, and the vast majority of errors made by the genetic counselors were classified as minor errors with, I think, a very small number of exceptions. If you look at the kinds of errors or the presence of errors based on the nature of the result, there was actually a difference. If you look on the left, so you're looking at the light orange are major errors, and the darker red or whatever it is are minor errors. And so on the left, the 3 categories are negative results, no returns that were deemed to be clinically meaningful. And in the center are variants of unknown significance, and on the right are positive results. The majority of errors on the non-genetic provider side were in the variant of unknown significance area, which a lot of it had to do with whether they were reported as potentially pathogenic or not. If you look at the genetic counselors, where the mostly were minor errors, most of them occurred, interestingly, in the setting of a positive result, that is, where there was a diagnosis that emerged from the sequencing. And if you look at a thematic analysis of the major errors made by the non-genetics providers, one was overinterpretation of negative results. The biggest concern was we didn't find a pathogenic variant, therefore this is not a genetic condition, which is obviously not a true statement. Omitting critical information was another relatively common one, as well as misquoting the recurrence risk, sometimes misrepresentation of information regarding what the test actually itself was, overinterpretation of uncertain results. A VUS was found and implying that it might have been the underlying cause, for example. Overinterpretation of positive results or misquoting of inheritance patterns happened occasionally. Here's a few examples of some of the kinds of errors. So in overinterpretation of negative results, providers said it was likely that whole genome sequencing would find a genetic answer, so a negative result rules out an underlying genetic cause, which I'm sure you would agree is not true. Omission of critical details, like not discussing recurrence risk on a pathogenic result that was inherited from a parent, or misquoting the recurrence risk, stating females would not have any symptoms of an X-linked disorder, where in fact for this condition they could be mildly affected. Misrepresenting the test, providers stated only 59 genes were looked at, obviously confusing the test with the ACMG secondary findings list, or overinterpreting uncertain results, suggesting that the current pregnancy might require additional testing based on an uncertain result, which we would not have used for clinical decision making. So the return of results was randomized, as mentioned, between either standard of care by a genetic counselor or by a trained NICU provider, and this was done as a clinical trial with a non-inferiority null hypothesis that the return of results by a non-geneticist would be non-inferior to return of results by a genetic counselor. This is a bit more detail about the protocol. So sequencing was completed, the babies were randomized between these two groups, and then a number of surveys were done of the parents at various time points after the return of results. And there was a specific set of tools that were used right at the time of return of results. And these include two validated measures of genetic counseling outcome and feelings about genetic testing results. So those were instituted right at the time after the return of results. And at least for those we have data now, there's still analysis going on for the various surveys. So looking at the genetic counseling outcome survey, about equal numbers of babies were randomized between genetic counselors and non-genetics providers. So you can see a significant number did not complete the survey. Among those that did, the scores were not significantly different between the return of results by a non-genetics provider and by a geneticist. So this realizes is pretty much immediately after the visit, and it doesn't get into the question of whether there was true understanding of the information or retention of the information. It's really, in essence, the parents' satisfaction with the process. So in this case, at least based on this measure, it was the return of results by non-genetics providers was deemed to be non-inferior, but there's plenty of other studies that are still ongoing looking at post return of results surveys and information retention and so forth. So I wouldn't assume that this is the final word here. A few examples of things that happen. This is specifically focusing on the UAB site, and there were many, many cases to choose from. These are just a handful that kind of illustrate some of the kinds of things that were found. So this first was an instance of a baby with renal hypodysplasia, and there was bilateral renal agenesis that had resulted in a fetal demise. But the mother, so obviously time had passed from when this baby was born to when that result came back. The mother was pregnant with another pregnancy at the time of results disclosure, and based on this finding, the genetic counseling was obviously impacted significantly, knowing what the underlying genetic cause was, which quite different from the kind of counseling that she had received previous to that. The second instance was this gene that's associated with a cardiac disorder that was paternally inherited, and as a consequence of that finding in the newborn and then ultimately in the father, it was then possible to offer testing for other family members, including siblings, based on their risk of having inherited this condition. And there was a third instance which resulted in a diagnosis of Nemeline myopathy type 8, homozygous variants, and there had been other testing done that was unremarkable, and it actually was deemed to be a lethal disorder, and it significantly changed the approach to care. And I guess I remember this, and I suspect Anna does too. This was a kind of almost emergency issue where there were a lot of things going on at once, and we got the results back at a critical point in time that factored very heavily into thinking about what further to do here. If you look at what the kind of big picture impact was, and so these are just some impressions based on the UAB site, and as I mentioned, there were sites at many other places as well. So before SouthSeq, and this may seem familiar, I suspect, it was pretty difficult. In fact, pretty difficult is likely an understatement, just about impossible to get genome sequencing done on a baby in the nursery, even if there was what you might have deemed to be very strong clinical indications. Because the testing was essentially institutionally billed, it meant that the institution had to eat the cost of sequencing, which could be non-trivial, and they tended to be very reluctant to permit these to be sent out. So there weren't many instances, as far as I know, where whole exome or whole genome sequencing was getting done on a case-by-case basis, but I doubt there were many instances where it was getting through. There were some rare cases where we have a state-supported project called the Alabama Genomic Health Initiative that provides funding for doing whole genome sequencing, but it wasn't really designed for this kind of acute inpatient application, so I don't think there were that many instances where it was used that way. In the post-SouthSeq era, there still is a need to run these tests by pathology, though this is a moving target, and Anna may have more up-to-date information than I do because she's a little closer to the clinical service than I am, but at least as of when this was put together, it still required approval to get it sent out, with a lot of effort to try to come up with more robust methods of getting this billed on a kind of reliable basis. And it really did change the perspective of the newborn medicine people, who became somewhat addicted to the ability to get easy genome sequencing. And they came to a point where they viewed that as just kind of something that they should have access to, and in fact sometimes complained if our staff didn't think it was a test that was clinically indicated, because they had gotten very used to a pretty low bar for sending it. So if you look at some of the other kind of benefits of SouthSeq, it did allow for testing of other family members, and it made a big difference in terms of genetic counseling for future pregnancies, as well as oftentimes helping to guide the care of babies in the nursery or making decisions about end-of-life care. It does provide access to the genome for future analysis, something I'll mention again in just a moment, and then really did kind of open up lines of communication between the newborn nursery and others in the genetics community. We also did have a component of this where the maternal fetal medicine group was involved. So some of the enrollments also occurred when there was a prenatal diagnosis that was suspected to have a genetic etiology that wouldn't have been revealed, say, by chromosomal analysis. And so we also were able to introduce this to the maternal fetal medicine, who also were not previously in a position where they would be able to get genome sequencing. It did increase their diagnostic yield. It made a difference in terms of their ability to offer counseling, and also whetted their appetite for having access to genome sequencing. So a few conclusions based on this experience. Over time, the nursery staff did show increased comfort with ordering genome sequencing in the nursery. And you can look at the results, I think, as either sort of half full or half empty, I guess. You know, on the one hand, errors were definitely made, and you can take the point of view that would be much, much less likely to happen with a trained geneticist offering the return of results as opposed to a much less trained nursery staff. And you know, it's a strong argument for why you need to have a geneticist in the loop. I would argue that may be true right now. I will say that the errors turned out to be generally pretty easily corrected, and there was a learning curve on the part of the staff, and it was something that over time tended to improve on an individual basis. And so it actually is likely, I think, that with additional sort of practice, this would actually have had even better outcomes. But, you know, that's a moving target because there are new people coming in all the time. Just parenthetically, you know, one of the interesting kind of experiences we had early on when we were recruiting the sites was that we went out to a group that was essentially a private practice. It was not an academic medical center, but it was a kind of a freestanding hospital that didn't have a lot of access to medical genetics. I think they had a genetic counselor, but it was a relatively small sort of service compared to the size of the clinical service. And to be honest, when I went out there, I guess I went out with the prejudice of an academic medical center. I thought, really, why does a private practice want to get into this? And one of the first things that the person who led the practice said to us, you know, we were providing funding for this to happen through the NIH grant, was, I would have done this for free. I really need to learn this stuff, and this is a chance to do that. So there was increased comfort. I think it gives us at least a kind of model for how to provide this kind of education. And I think over time, it's likely to become something that will be easier and easier to do. It definitely increased the expectation on the part of staff to have sequencing available in the nursery. It would frequently expedite diagnoses prior to discharge, and babies would be less likely to be lost to follow-up, though some were, as I mentioned earlier. And there were some examples of changes in management and counseling. The final clinical trial analysis is ongoing, but at least that one survey showed non-inferiority of return of results by the non-genetics professionals. So final analysis, I hope, will be reportable over the course of the next few months. That continues to be an ongoing effort by the group that was managing the clinical trial. I guess the other point I'll make is that if you look at the diagnoses that got made, and I'll tell you this is my experience with genome sequencing generally, and I'd be interested in hearing whether it's yours as well. Almost none of the diagnoses that got made were on anybody's differential diagnosis at the time when the test was sent. So, we're used to pre-sequencing. You would see it might be a baby or it might be an older individual, whatever, but where you look and you try to make a diagnosis based on clinical features, and then you send the test or tests most appropriate for that particular hypothesis. And sometimes you're right, you get a diagnosis, and of course, not infrequently, you don't come back with anything, and yet you're still left with an individual who has some kind of phenotype that you wish you could explain. And all of the obvious diagnoses, I think those get made pretty effectively with what you might describe as standard, let's say, non-sequencing based approaches. At least in the patients I've personally seen, and I think it was true in the SouthSeq babies too, if it took genome sequencing to make the diagnosis, it's almost always something that nobody was thinking of, and I would say most of the time nobody had ever even heard of until the gene was identified. Once in a while, we'd come up with something that in retrospect you say, well, gosh, I wish I had thought of that, but I didn't. And usually we're at the end of a long line of people that didn't think of it. And, so it is occasionally the case that you'll make a diagnosis that you could have, if the right person had seen that individual, would have gotten made. The problem is, of course, lots and lots of people who have phenotypes don't see the right person. Even if it's a good person, it might not be somebody who's had personal experience with that fairly obscure disorder. So it is interesting to me that high proportion of the diagnoses, almost all of them, were things that were kind of out of the blue from our point of view and probably wouldn't have gotten diagnosed ever until sequencing was done. Now, just in concluding, I wanted to mention one other project, which is a little bit off topic, and it's not really meant to be a successor to SouthSeq, but it is another project that you may be interested in hearing about briefly. It's called BabySeq, and that term may be familiar because BabySeq 1 was a project done as part of the NIH EnSite program looking at sequencing as an approach to newborn screening that was done in a number of sites. The BabySeq one was at Brigham and Women's Hospital and other Boston hospitals a few years back, and their results continue to be reported. But this is actually BabySeq 2 now, and it is a collaboration. You can see at the bottom multiple sites. The primary site is Brigham and Women's Hospital, or I guess they call it Mass General Brigham now, and then there are several other sites, including UAB and the Icahn School of Medicine at Mount Sinai, and then you can see there are several others that are part of this as well. So this is not diagnostic sequencing. These are babies. Actually, it says the first 6 months. I think it's been up to the first year of life now. The goal is to enroll 500. This is funded through NCATS in the CTSA program. And babies get randomized either to just having family history taken or having whole genome sequencing and family history done. And then there's a return of results of childhood onset disorders that might or might not have been clinically recognized, some actionable adult onset disorders, essentially like secondary findings, carrier status generally for recessive conditions, a handful of pharmacogenetic variants, and then if a baby actually evolves towards having a phenotype, because at the time of enrollment, most of them do not, then indication-based testing can be added on, and they get results by a genetic counselor. There actually has been, in fact, it was the same educational program that Hudson Alpha put together for SouthSeq is also being used in BabySeq, but we're not expecting the pediatricians to return these results. All of the results are returned by a genetic counselor. There are lots of surveys of psychosocial and medical impact. There is an effort to look at healthcare utilization and costs. We have a stakeholder board because here too there's an interest in enrolling people underrepresented in biomedical research. So this has actually just gotten off the ground after a long, long runway wherein now enrollment has begun at all of the sites over the past few months. So it's going to be a while before that 500 mark is met, but it is well underway. All right, I'm going to end at this point. Just want to acknowledge the fact that there was a very large team involved in the SouthSeq project, including at Hudson Alpha, many at UAB, University of Mississippi, University of Louisville, Women's Hospital in Baton Rouge, Children's Hospital of New Orleans, and the engagement efforts were led by SERN at University of Utah. With that, I don't know if there's time for questions, but I would be happy to take any. Thank you.